So there's State's Exhibit number 1. He actually had a baby. That's why he's not here today.
State's Exhibit.
So, and I tell you, he's been a wonderful chair. I mean, he's worked with our executive director and done very well. We have a couple other people that have meetings that will be joining us that are on the commission, but we have a quorum, so I think we're going to go ahead and start now. So I thought we would introduce ourselves, and we'll start with Larry Landis. Larry?
Thank you. Larry Landis, Indiana Public Defender Council.
I'm Susan Lightfoot. I'm Chief Probation Officer in Henry County, and I represent probation for the state of Indiana.
My name is David Powell, Indiana Prosecuting Attorney's Council.
I'm Chris Blessinger, Executive Director for the Department of Correction for Division of Youth Services. Sorry.
Loretta Rush, Indiana Supreme Court.
Dave Rizal, State Representative.
Terry Stigton, Director of the Department of Child Services.
Jason Devick, State Budget Director.
Mary Willis, I'm the Chief Administrative Officer for the Indiana Supreme Court.
All right, this committee had the opportunity to look at the previous minutes from February 14, 2018. Any corrections or changes? Is there a motion to adopt those minutes?
So moved.
All right, second?
Second.
All right, all those in favor say aye.
Aye.
Great. Our first item on the agenda is the strategic priority of child safety and services. Dr. Leslie Helbershorn will talk about the Zero Suicide Academy. They are asking for an action item from the commission, and that would be to endorse this academy. So the information has been provided in advance. Dr. Helbershorn. Good morning. Thank you for coming.
Thank you for having me. So, a collaborative effort on the part of a SAMHSA grant awardee, which is Community Hospital System, along with FSSA, which is for the Division of Mental Health and Addiction, and our group, the Child Safety and Services group, would like to request that the Commission endorse holding a Zero Suicide Academy. So what is that? So Zero Suicide is a framework that has been developed that is designed to help reduce the risk of people falling through the cracks within healthcare systems. So it utilizes evidence-based screening tools that are age-appropriate, and then figures out how healthcare providers can make sure that information is captured and viewed as important and identified with the patient as they go through the healthcare system. So it has been found to reduce the suicide rate among organizations that use it, and the way you become an organization that uses the Zero Suicide Framework is you attend an academy. So so it costs about $50,000 to host an academy, and the SAMHSA grant that Community Health Network has is going to cover the cost of that. The hope is to, well, not the hope, but the plan is to hold it at the Government Center on July 25th, which is unfortunately timed because of the already planned.
Can that date be changed?
Well, so the problem, so I didn't know this date.
If you could speak a little closer to the microphone, can you hear her in the back?
Okay, is that on? No? I'm not sure if that's on. Or maybe this one?
No, just the other one's media. That's good. I think it's here.
Okay, I'll just speak louder.
All right.
Okay, so the way it works is a state or entity asks the Zero Suicide faculty when they can come, and they tell us the date. And so evidently what happened was they said July 25th and 26th are the dates of the 2-day thing, and so I don't know, we can look into changing it. It's just for those who aren't aware, that is also the date of a very important meeting focusing on the opioid epidemic led by the Supreme Court. So anyway, dates aside, the request is to have endorsement from this group for the fact that this is an important initiative, and also to help spread the word about this and encourage healthcare systems and community mental health centers to participate. So those are the target audiences, and we could have up to, I believe, 30 of them participate. So it's a big meeting, and it's not just, hey, come and learn about zero suicide, but it's come and begin implementing zero suicide in your organization. So an organization has to be ready to go. So that involves some prep work in advance on becoming, ready to do it.
Can you give us a little background? Indiana is one of the highest rating states for teen suicide. Can you give us a little background on why this is coming here and what the importance in this
Yeah.
place and time?
So this is a national effort. So SAMHSA, this is the Federal Substance Abuse and Mental Health Services Administration, and the federal government has identified this as a best practice and a technique to reduce the suicide rate. So this is something that's being done all around the nation. And Indiana has received a grant in the past to pilot it in a couple of different mental health centers, not a couple, like 12, I think, as well as some healthcare systems, and that went well. So we've had an academy already, and now the goal is that, it seems to be working well. The agencies think it's helpful, and there's a lot of NIH-funded research demonstrating that, in fact, this probably is best practice. And so the goal from SAMHSA's standpoint is to get this all across the nation as utilized in every healthcare system if possible. So a lofty goal would be every healthcare system in state, eventually would be utilizing this, but now as a starting point, let's get all of the mental health centers on board, community mental health centers, and a number of local hospitals on board with this model that we think does reduce both youth and adult suicide. So I know that more info, if that makes sense. So this is also an opportunity for those who are interested in legislative or policy action around the concept of suicide to come and attend and learn what our best practices, what our directions that the state could be going, even though they won't be implementing the model themselves in their own organization. So that was one of the requests of our work group that's working on this, is to say if the commission wants to advocate for this and spread the word and lean on hospital systems that they are familiar with or others that should be attending, that would be really helpful. Questions or other things people need to care about?
How does it work? I mean, how does this roll out to move the needle with regard to the number? You had in the report, it talked about 1 out of every 4 children and active teenagers in Indiana actively think about suicide. That's a high number, and then the actual number of suicides.
Yeah.
What is this? How does this move that with regard to reaching the children and providing the mental health services that are available? Because I recall that when I had a child in an acute state in the ER, it was hard to find a place. The children's mental health, the unmet mental health needs of children is very high in Indiana.
Absolutely. So the way this would work is a child who would maybe share with a school friend or a parent or someone that they're thinking about suicide would need to be assessed. Currently, if they were assessed for suicidal ideation or behaviors, most providers in the state are not using evidence-based screening tools, and they're not asking many of the right questions that need to be asked to really determine the risk. So this would train providers on, here are the screening tools that are really helpful, that we know are evidence-based, to help us pick up on the severity of the situation. And then often what happens is the organization that screens for the suicide just says to the parent, hey, good luck, we know your kid needs help, here's some phone numbers, right? And this would say, okay, we've identified the problem, we've quantified how serious this is, and then our system is going to flag this child within the electronic medical record as needing priority treatment, and we are going to have a special policy, a set of procedures that are different than what normal healthcare organizations would do, that would initiate treatment immediately, get them in with the right people, have someone phoning to follow up to make sure they haven't fallen through, because we know a lot of folks come to the emergency room and then never ever make it to treatment. So it's not changing the treatment that's delivered, but organizing it so that the person doesn't get lost in that very complex system of interfacing between emergency services and mental health services. So it doesn't use any different treatment models, for example, than would already be in practice, but it identifies the kids better and links them in with the services more tightly, and then tries to create a safety net so that they aren't lost to follow up, is I think one way to explain it. There's a lot of information on the website that goes through in a lot more detail, but that's the gist of it, I think, is the way that the person is captured in the organization.
And we actually, you provided on our website attached the agenda. We had the information. Any questions from the members on the commission on the recommendation of endorsing Zero Suicide Academy for Indiana?
And certainly, if you have any influence on healthcare organizations or mental health centers that you can encourage them to participate, that would be really helpful.
All right, is there a motion? And then you also, there's a second item here, identify stakeholder representatives for that.
Well, so that's that second thing I just mentioned. We know a list of folks we are going to approach and ask, but if there are specific entities that you all feel really need to attend this and are a priority based on the work you're doing, we would love to offline find out who those are, and if any pressure you can put on them to participate would be helpful.
Madam Chair, I want to ask the question. I'm sure that Julie might have the answer to this. I'm assuming I'm all for this. I'm going to vote for it, obviously. I think it's a great idea. But my concern is getting people there for the July meeting. So I'm assuming that we're going to have a coordinated effort to do so. I'm just asking the question and follow up on all those other things that come along with it.
We could certainly work together on that.
Okay.
Can I ask one question?
You can ask two, Dave.
How many people can come?
So I think it's 30 organizations, and within each organization, it's usually a small leadership team. So I have to find out these. I think it's like 3, 4, 5 people per group. However, the planners have said we really want to make sure there are also spaces available for legislators or other folks who are just interested, from a, policy standpoint.
But your target group are medical folks.
Yes, hospital systems and community mental health centers.
Thank you.
Any other questions? Is there a motion to endorse the Zero Suicide Academy for the Children's Commission?
So moved.
Is there a second?
Second.
Any other discussion? All those in favor of endorsing the Zero Suicide Academy, say aye.
Aye.
Opposed? Wonderful. And Dr. Halverson, you're on the Child Safety and Services Committee. They're looking at suicide as well. So have they taken this? And Julie, maybe somebody can answer this, sort of build on this with regard to the group
Yeah, so our mission with regard to youth suicide on the Safety and Services Task Force is to promote the use of zero suicide. That is our current singular mission. So I expect that might change over time, but right now this is perfectly in line with what our group is trying to do.
The studies in the report that you sent us to prepare for today had some pretty remarkable numbers on success for this. Are you following up with any of those states or?
Yeah, I think what we're really looking at are peer-reviewed published studies that have been done that have tried to eliminate variables that would maybe inflate those numbers artificially. And so those are studies that are being undertaken, like I mentioned, by the NIH. So we can absolutely reach out to other states and find out more about how it's working from their standpoint. But it does seem like the science is legit here, which is why SAMHSA is so on board with this.
Thank you. Let us know what we can do to help promote that event. I wish it was on a different day because the statewide opioid summit is that day as well. All right, thank you.
All right, thank you.
All right, Dr. Zachary Adams is going to give an update from the trauma subcommittee, who I also saw your name at the opioid. You will be presenting at the opioid summit as well.
I will.
All right, excellent.
Well, good morning. My name is Zach Adams. I'm a clinical psychologist and faculty at the IU School of Medicine and the Department of Psychiatry, and I'm a psychologist at Riley Hospital as well. So thanks for the opportunity to share a brief update on the work we've been doing in the Child Trauma and Resilience Work Group. My goal today is to provide a little bit of context of what that group is and what we've been working on. So last November, in the chairs meeting from this group, it was recognized that most of the task forces, in fact all of the task forces, have at least one objective related to childhood trauma and resilience, and whether that has to do with workforce development, training, response to childhood trauma. It's a common thread that runs across the task forces. So in its collective wisdom, the group of co-chairs suggested that it might be good to convene a group focused on that common thread to avoid any redundancies, duplication of efforts, and to promote some efficiencies in the work that we're doing. So we started meeting in December. There are representatives from each of the task forces on this work group, and we've met, I believe, 4 times now. And in those meetings, we've done a few things. So one is to review all of the objectives that are related to childhood trauma and resilience and try and find some common themes and common, opportunities for us to share our resources and to share our networks. One example of that, most groups have a goal of making sure that the workforce in various child-serving agencies and systems know about childhood trauma and its effects and impacts and how to reduce incidents of childhood trauma and promote healthy outcomes for kids and families. There are a number of different efforts underway and under study, both here in Indiana and nationwide, that address that goal. And so we've been trying to say, well, what are the resources now? What are the gaps? What are some opportunities outside of Indiana that we might be able to draw upon and use sort of collective resources to offer that to folks in different service sectors. Another example of that is in a recent meeting, for example, we identified an opportunity to draw on the National Child Traumatic Stress Network's resources to train the juvenile justice workforce around childhood trauma and how to integrate best practices. And so we sort of worked together to come up with who could be the trainers, who could support that work. I think it was a nice example of pulling together to sort of bring something that we think is good potentially to Indiana. I guess one other goal that we've identified is coming up with a common language and sort of generating a glossary that helps us to make sure that we're all on the same page when we're talking about trauma, trauma-informed care, the effects of trauma, resilience, and so on. And I'm not prepared to share a recommendation on that front today, but that's another example of some of the things that we've been up to. I'm happy to answer any other questions that you might have, but really just wanted to introduce the group and what we've been working on. And we plan to keep meeting and really start focusing in on a couple of measurable goals and tracking that progress, and hope to be able to report that at a future commission meeting.
Any questions from the committee? I had a question. Is there some, in looking at just nationally, in reading a lot of information on the number of children that enter the child welfare system, that in and of itself is an adverse childhood experience. Are you looking at models or best practices or evidence-based services that can be incorporated into treatment plans or court-ordered services for children, given the large number of children that are entering the child welfare system in Indiana right now?
Yeah, so I can't speak specifically to that point, but I think that notion is a really good example of why we're putting our heads together on this, because every single step in the process that a kid is following when they're either taken into care, whether it's by the state or by family or whatever the case might be, is an opportunity for those various systems to promote resilience, to help kids thrive. It's also an opportunity for additional trauma, stress, adversity, and so on. There are good models. We've been talking about the various workforce development efforts that are out there, and that is a goal of those, is to say, what can we be doing from a policy, procedure perspective in our various agencies and organizations to meet this common goal of helping kids thrive when they've experienced something bad in their lives. So I can't speak to a specific program right now that we're saying, yeah, this is what we're going to jump on. But that's a great example of I think, why we're convened as a work group of constituents from the various task forces.
We're really looking at that for the judges with regard to dispositional plans, whether it's a delinquency case, paternity case, a CHINS case, with regard to what are the gold standards for what we're, not gold budget director as far as costs, but what are the evidence-based, what should we be doing or providing for these children that come in? Are we providing the right services for them given whatever their age would be?
Judge Pratt sits on our work group, and we've had conversations around this point. The initiative or the program that I was mentioning before for juvenile justice staff can also be adapted or promoted among folks who are involved in the court system at various levels. And Judge Pratt was advocating that we need to be sure that folks who are responsible for court procedures and so on are at least familiar with what other folks throughout the system are learning about. I think to do just that. That it can't just be about folks who are in the corrections probation world, but also folks on the court side and on the advocacy side.
Great. Thank you, Dr. Adams. Any other questions from the committee for Dr. Adams? All right, thank you.
Yeah, thank you.
I apologize for the ringing. Anybody here ringing?
Yes.
Representative Wendy McNamara. She has been leading our Child Services Oversight Committee and been doing a wonderful job. on that. Can you give us an overview on what you're looking at on that? And you may have some questions about the work of the policy group looking at it and what your plan might be for taking some of those charges. I don't know.
Just thought I would get it out.
Okay. You could.
All right, we met in February, which I believe Director Stigler might have been on the job 2-3 weeks maybe, so as far as getting updates from TCS, at the time we just looked at the initial progress report for the child welfare policy group report, and had some discussions around what the next steps are, and I'll talk about those in just a second. We also had information from the Bassett Children's Home and the challenges of educating youth in group homes and some of the challenges that they're facing, but probably one of the more interesting conversations with CASA. And they served over 29,000 youth in 2017, and 18,000 of those were carryovers from the prior year. So the turnover, the court time, the number of kids just awaiting is still a significant number, a significant challenge to be addressed. Although the funding for CASA has increased, the challenges for CASA has increased just by the sheer number of cases to deal with. Going forward, it's my intent with our task force, or Betty, I guess that's what we are, to take the report that is delivered by the Child Welfare Policy Group, and if it recommends any legislative fixes, this task force or this group, this committee, will put together the people necessary. Many of the people are already at the table, probably already working on some of the same issues that the report might find. And we're going to meet on July 18th to go over the report. The report's supposed to be mid-June, I believe. Yes. Is that correct? Okay. And then from there, we'll put a working committee together to address some of the concerns or anything that is highlighted in the report that will come. Some of the legislation from this session, House Bill Act 1414, will start to collect data on foster care youth and their outcomes in education. And where are you at, Joshua? I want to introduce Joshua Christian. Joshua came to me this session. He spent his life in foster care. Recently adopted at 18.
Well, I'm with America on 18.
Okay.
Yay!
I'm going to ask Joshua to attend a meeting in July to be a voice and advocate for foster care across, because I don't know, how many homes were you in? 18. He was in 18 different homes in his lifetime, in his 18 years. So Joshua, as you can tell just by the way he presents himself in a second, is going to be a perfect advocate for those. Several other bills, foster care bill of rights, insurance designations, and some information on BCS. But going forward, it's our hope to take the report and delve into whatever recommendations that the report makes, and if they require legislative fixes, work on those particular things from the people that we have in front of us.
Any other questions? Any questions, Representative McNamara? All right, thank you.
Thank you.
All right, next, the strategic priority of juvenile justice and cross-system youth. We have Don Travis. Oh, I'm sorry, Gretchen Martin from the State Department of Health. Yeah, this is important. Statewide Child Fatality Review Committee, the annual report.
Good morning. Thank you very much for allowing me the opportunity to speak on the work of the State Child Fatality Review Team. So this, the information that I'm presenting is based on the work of the Child Fatality Review Team in 2016. And a little background on the report. From all of you probably had some infant mortality information in the past, but just to kind of recap a little bit, from 2011 to 2016, more than 3,000 infant lives have been lost in Indiana, and sudden, unexpected, or unexplained infant death, or SUID, is the third leading cause of death for infants in Indiana, and most of those deaths are preventable. Also, the CDC research has revealed that U.S. SUID rates are misattributed, or SUIDs, sudden unexplained infant deaths, are often misattributed to other causes of infant death. So with that background, the statewide child mortality review team decided to review SUID cases for a calendar year. So we looked at the time when we started this, the 2014 data was the most recent data available, so that's why we chose 2014. So when we started the process of reviewing these deaths, the committee had some goals. To evaluate the quality and completeness of infant death reporting from the local teams, and determine if SUID investigations were being conducted as recommended by the CDC using the SUDI, or Sudden Unexplained Infant Death Investigation Protocol. Also to classify the cause and manner of death using the CDC SUID case registry algorithm, and identify sudden unexplained infant death, or SIDS, sudden infant death syndrome, risk factors, and formulate prevention and recommendations based on that information. So the methods that we used, the statewide committee reviewed sources from death certificates, autopsy reports, the Department of Child Service records, and the National Center for Fatality Review and Prevention case reporting system. And that case reporting system is the data system that the local child fatality teams enter their data. So what we did was we pulled vital records data from 2014 for all children and had 233 deaths identified. We then kind of pared that down to deaths of just infants, so birth up to a year of age, which brought us down to 132. And then we excluded those deaths that didn't occur in a sleep environment or didn't meet the case registry criteria. So we removed 27 of those and ended with 105 total SUID deaths. So the SUID case registry algorithm is basically, and it's on page 15 if you're interested in looking at the report that's in front of you. This algorithm is basically a decision-making tool to help us learn to review, collect, and enter information in a standardized way. So it kind of walks you through this process so we have accurate, objective, and comprehensive surveillance data. So basically everybody's using this algorithm to look at things the same way. The CDC also recommends 3 causes of death to fall under that SUID umbrella, and those would be SIDS, which is the sudden death of an infant less than a year of age that can't be explained after a full autopsy, a full death scene investigation, including medical records, examination of the medical records. So basically SIDS is a diagnosis of exclusion, meaning that there was nothing found to be a cause of the death. And then unknown is the sudden death of an infant less than a year of age that remains undetermined because one or more parts of that autopsy or death scene investigation were not completed. And then accidental suffocation or strangulation in bed, which is pretty self-explanatory. The child was suffocated or strangled in the bed. So the case registry process was that basically that you identify the SUID cases from the coroner and vital records, you review information from the death scene investigation, autopsies, medical records that we've talked about, you identify actionable strategies that may reduce SUID and improve your case investigations, and then you report your findings into a web-based reporting system. You analyze the data to monitor SUID trends and characteristics, and then you use that data to inform strategies and recommendations and prevent future deaths. So some of our key findings from this review were at least really hard to read. But the pie chart on the left on the screen shows what our vital records data showed. So when our MCH and epidemiologists pulled information on child deaths in 2014, they identified that 14.4% of those deaths were related to SUID. When the state team reviewed that same information, we identified 19 additional cases that would not have been captured under that data pull from vital records. So that would essentially raise our SUID rate in 2014 from 14.4 to 17.6. So it's a much larger problem than we realized if we're just looking at vital kind of shows one of the things that we hope to show local teams with this report also is how valuable their information is. Because there's really no other place that you can gather all of the risk factors and circumstances involved in these deaths and look at how can we inform prevention except through child fatality review. So another finding was that we have a lot of missing investigation data when we looked through these records. So again, the pie chart on the left shows the distribution of SUA deaths identified through vital records, and that showed 4.7% of those cases that would have been determined unknown, meaning that an autopsy, a full autopsy or full death scene investigation wasn't completed. When the state team conducted their review, if we stuck to that algorithm specifically, we identified 89.6, I believe.
89.5.
89.5, thank you. 89.5% of those cases would have been determined unknown, meaning we didn't have enough information from the autopsy or the death scene to really accurately determine the cause of manner of death. So, just to kind of add to that a little bit, a death scene investigation we found was conducted in 87% of those 105 cases, which honestly, if it's a sudden unexplained death, we should have had a death scene in all 105 of those investigations. A majority of the SUA deaths had a partial death scene investigation, not all were complete or included the necessary documentation. And only 48% of the autopsies were conducted by a forensic pathologist in that year, 2014, which despite statute is required. And x-rays were only taken in 51% of these investigations. And an x-ray is a mandatory procedure in a full and complete autopsy. So if there's no other takeaway from this report, I think this is the most impactful. The key findings were that of those 105 cases that we reviewed, 99 of those babies were found in an unsafe sleep environment. 4 of them, we did not have enough information from the death scene and records to determine, and 2 of them indicated they were not in an unsafe sleep environment. So again, I mean, to me, that's really impactful. 99 of these 105
Can you give an example when you say, so almost all of them died because of the way they were sleeping? Give some examples.
So, and there are more examples in the report, but they were found at least with one unsafe sleep factor. So that could be they were found on their stomach, they were found in an adult bed, they were found with pillows or blankets, something in the crib with them. So at least one factor of unsafe sleep was determined.
I've got a question. I noticed in your report that you cite substance use in these cases, but in the decision-making algorithm, it doesn't appear that substance use is part of that. So do you know of these 105 fatalities from 2014, how many of those where substance use was a factor in a primary or secondary caregiver?
And if you can hang for just a second, we'll kind of get there and I can answer more questions if you have.
And I guess my question would be, why would that not be a factor, an unsafe factor in your algorithm informing the study? Because you're only looking at things like face presented into or obstructed by soft bedding and the environment around the child, but you're not taking into account that a parent may have been incapacitated in sleeping with that child. And I think that is a very, very important part of any investigation into infant deaths is the capacity of the parent at that time if they are co-sleeping. Now we know that co-sleeping in general is unsafe, but particularly when you have a parent who is taking substances that further incapacitates them in their ability to properly care for a child. Just wondering why that wasn't, that's not considered a factor in any of these in your algorithm.
So the algorithm is the algorithm used by the CDC in their sudden unexpected infant death registry. So the purpose of the algorithm is just to walk you through the risk factors associated with that death. So, were there unsafe sleep factors present, and then were those factors including the breathing or was the child's face in the mattress, that kind of thing. So it's really just to walk you through a way sure we were pulling all of these other risk factors. So we pulled things like, was there substance use involved? Not necessarily that the parent was impaired at the time of death, but was there some history of substance use or abuse with those caregivers? And things like domestic violence in the home, those kinds of things.
So you're saying you did look at those things, but the CDC's algorithm doesn't account for it?
The algorithm does not account for it.
Also, just to make a clarifying point, much of this data that Gretchen looks at comes from autopsy reports, et cetera, and so that's not accounting for what's happening in the parent. Not all of the caregivers are tested at the time of death, et cetera. In fact, most are not, and so that would be adding a very, very incomplete data set to an algorithm that's really based on the standardized mechanisms of collection for the scene. So additional data.
You are tracking when you know, I assume.
Exactly. So it's additional data, just not in that
Right,
standardized collection form.
Thank you.
Since we went up to Jason, I just, I get where the number 105 comes from, but then when I look at your pie charts on page 8 of your handout here, you have 597. So what is that? What does that number represent? That large 597? And I understand it's still down to 105, I think, at least on some of these other examples. But I'm not sure what that number represents and why. What was the? Why were you at 14% in one review and 19% at the other? Is that missing information that prevents you from being able to determine or conclude? So there's two questions there. Okay, what's the difference between 597 and 105, and why is there a distinction between 14% and 19%?
Can you tell me where you're looking?
I think she's looking at the total infant deaths for the year, and then you're talking about just the SUID deaths. Yes.
So these are the total deaths, but they're infant deaths. So the difference is these are all the deaths and all the possible reasons for why a child died. And you just narrowed down to 105. And then so why is there a distinction in those key findings? And this is where I am in the little graph that I found, where you said that there was 14 point, and I can't really see it, 14, and the other one when you did a different review, it came up to 19. So why was that discrepancy coming from?
So the discrepancy comes from the fact that if we just use the ICD-10 codes for SUID to pull from vital records, that's what our epidemiologists use. And they determined in 2014 that we had 14.4% of our SUID deaths were the result of SUID. The state team identified 19 additional cases that would not have been pulled by the epidemiologists at that grade.
So why is that? Why would the epidemiologists not have pulled those 19 additional cases? Is it the kind of questions that we're asking, or is it we're missing information?
It's probably the way the information is written for input onto the death certificate. So it may be that you have a cause of death listed as respiratory arrest, and then when we really dug into the case, found that the respiratory arrest was due to positional asphyxia while sleeping in an unsafe environment. Does that make sense?
Yeah, I guess we need to figure out how to bring those closer together so we don't have to. So whatever that question or answer or definition is that needs to.
Yeah. And I'll get to that a little bit here in a second, how we hope we can do that, how we've tried to do that since this time. Again, some of the key findings was we want the local teams to understand how important this information is when we're talking about prevention. So we looked at how many of these cases have been entered into the death reporting system by the local teams. And what we found is that only 37 of those 105 cases have been entered by the local team. So we're hoping again to use this report to help, kind of help the local folks understand the importance of this information in addition to the accurate identification and classification of these deaths. It also, our key findings gave us some information about who was the supervisor at the time of the incident. So who was that person that was responsible for placing that child in that environment. And we found that 62% of those were biological parents, and then 9% were babysitters, and we had no response for 24%, which again just highlights the need for better data information about the sleep environment. So it's, again, it's not enough for us just to know we have this many babies that die of sudden unexplained infant death. We found that at least 64% of these deaths, there was a crib in the home at the time of the death. It either wasn't being used appropriately or wasn't being used at all. It also gave us some information about where, if the child is not using the crib, then where are these deaths occurring? And I think that says 60%, I have a hard time, 50 or 60%. 50% of the deaths occurred in an adult bed, and 14% in a crib and 13% on a couch. So this just gives us a way to really target our prevention.
Well, when you say target the because that, when you look at the focus on infant mortality, that half the children dying of SUID are because they're sleeping in their parents' bed. When you're looking at prevention, I mean, what are the steps in place? What are the steps that need to be in place? And Dr. Warthel, maybe you've got some ideas on this too, because we've got to get that message out there and blast it. I mean, half the children dying in this category are dying because they're infants sleeping in their parents' bed. Is there anything in place? I mean, I've seen some safe sleep billboards, but it's pretty, I don't see a lot.
Hugo, you're living this every day, right?
So at ISCH, we have a safe sleep program. We have currently, I think, 160 or around 160 distribution sites or education sites across the state where anyone in need of a safe place for their infant to sleep can find that resource. So they get a free pack and play, a pacifier education on safe sleep. And one of the things that we're really working on is not just talking to the mom or dad about the safe sleep area, but also as influencers, so grandparents, talking to their child care providers about making sure that child care providers are following safe sleep recommendations and that sort of thing. So at this point, we're trying to reach out to anybody we can and make sure that they have the education.
I wonder how we can help. I mean, how our different organizations can help on that. We have a communications team now for the Children's Commission. It sounds like this needs to just be blasted.
So the Labor of Love campaign that launched in early 2015, Safe Sleep was the third main component to make that a very simple, easy to follow set of guidelines for moms and families and communities, really. The difficulty in penetration is just like any other, when you're doing an educational campaign or outreach, is that we reach the same people that we always reach. And how do we make sure
leverage
those,
like social media or
right, so the team really does a good job. So I think it's not more of what we're already doing. It's making sure that we really understand the disconnect in cultural relevance. I think one of the things that we talked about most recently is how do you turn safe sleep into something that means something to everyone that you talk to? So we have a message that resonates with a mainstream group, but how do we make sure that we make safe sleep culturally relevant every sleep, every time, every population? That it's not talking about someone else, it's talking about me. And I think that's really our largest challenge. There are some big groups that really advocate for co-sleeping, and so we have an active, really potentially hostile dialogue that's ongoing all of the time for bonding between mom and baby occurring with co-sleeping. So we have to make sure that outreach is gentle and kind and not you're wrong and you're a bad person, but how do we make sure that we promote bonding and family connectivity without being
maybe just the education that half of the children that are SUID, that have sudden unexplained infant death are in an adult bed. Just that education piece, because were you all startled to see that?
So there's much work to do. I mean, one of the most, I think, potentially the most heartbreaking thing that we do in the emergency department is have an unsuccessful resuscitation of a co-sleeping death in a perfectly healthy infant.
Lots of mamas and babies sleeping on sofas, and the baby gets rolled over.
Well, Charlie, one of our big partners is Charlie's Foundation out of Ohio. That was actually Charlie died in a nap on the chest of his father, who was a pediatric cardiologist. So again, this doesn't see any demographic or knowledge. This is, doting father, very educated, really tired. Right? So that's why we really promote that ABCs of sleep every time. It's not just at night. It's not just naps and everything else is all on the table. So it's really tough. And I think one of the things, Chief Justice, that we really have to model is that this has to occur in our facilities as well. So one of the great things that our hospital partners are doing is modeling safe sleep in hospitals. When we started this campaign just a few years ago, you would walk into a hospital room where a baby was in the hospital and they were on a monitor, so we knew what was going on, but their diapers and their toys and their blanket are all in the bed with them. So we can't model it in the healthcare setting. How can we ask folks to do it at home? And then one of the things that FSSA is really working on is promoting safe sleep practices within childcare settings. We license all of childcares across Indiana, and there should be 0 unsafe sleep deaths in licensed childcare facilities. And so making that part of our certification criteria and surveillance as we go out and look at whether it's a large childcare all the way to a home, that safe sleep is the #1 thing that we're talking about, is a high priority for us as well.
Are there certain demographics that can be targeted, that need to be targeted? Are there more young parents who are having this kind of issues, or financially challenged? Is there a specific population that really has a challenge with this issue?
Well, we have disparities within this population as well. So our African American babies were 2 times as likely to die as than white babies. So that's definitely somewhere. I want to say it was like 27% of the babies that died this year were Black or African American, and only 9.5% of population. So that's definitely some place that we have been focusing. Also, I think young parents and folks who are lower income levels, from what we found from the report. I also kind of wanted to add on to what Dr. Wellfeld was saying about Charlie's Kids. You guys probably have seen the Sleep Baby Safe and Snug book. And if you haven't seen that, I'm happy to bring some for the commission to see. But the Sleep Baby Safe and Snug book was written by Charlie's parents, the pediatric cardiologist and his wife, and we are working with Martha and our MCH division to provide these Sleep Baby Safe and Snug books to all births in Indiana. So hopefully, and there is some research that shows providing this book with education is a lot more beneficial than a brochure or a video watching. I don't know, you guys, if y'all need me to hurry up, please tell me.
You're good.
Okay, so here's to answer your question about substance use history. This isn't necessarily impairment at the time of death, but it's just that there was a history of use or abuse in the home. And you can see that marijuana seems to be a significant factor in these deaths.
I have a question about that. Can you back up?
Yep.
I'm surprised that alcohol is so low. Is that because, how do you measure abuse in alcohol since it is legal? And at what point does it become abuse? And as opposed to the other drugs that are illegal, I assume any use is abuse. Is that correct?
Well, and again, this information would have been pulled. We would receive most of this information from our DCS reports, number 311 reports that we were reviewing. So if we found any information about there being a history of alcoholism or misuse or anything like that, we would have classified that as use or abuse.
So is any use abuse, or that's really my question is, at what point does use become abuse? And how is that measured to only get that low? Because alcohol is still the #1 abused drug.
Again, it would be the information that we would have received through the DCS investigation and for the law enforcement report. We have it. So we have to kind of go by those findings within those reports. The local teams, though, however, have a lot more information because, especially in smaller counties, they oftentimes know the folks that they're talking about. They know the history of law enforcement, the history of mental health, and every history that you have in the community. So a lot of times time the local teams have a lot more information.
Could I suggest another drug that we start tracking, which is benzodiazepines? And I listened to Dr. Anna Lemke on Dr. Radio talk about that the other day. We're going to bring her in from Stanford Medical School this summer to talk about the abuse of sleep, Ambiens, Xanax, and Valiums. I was stunned at how bad that is in this country. Probably worse than opiate, just don't die from them necessarily, but lots of cognitive problems and abuse. And I just wonder, in that 7% there prescription, if that's not dominated by benzos. I mean, we're seeing benzos in all the tox reports anyway, so that might be a drug you consider tracking, prescriptive drug.
We do have the ability to track that if the teams are gathering that information and entering it into the database. It will allow you to kind of break down that other or prescription drug.
So you have that data, or you can get that data?
I can check and see if we have.
That would be interesting.
Yeah. I would have to do that.
Hi, me again. So going back to the issue of substance abuse related to these fatalities, do you track, I know you're saying that these numbers are just not even at the time necessarily of the incident. Do you, and that may be, dependent upon the good reporting from DCS and law enforcement to document those things, but when we saw the last report out of the Department of Child Services for things like drowning and co-sleeping, those were the two main factors for child fatalities, but substance use, particularly marijuana use, was noted in most of those cases. Now, again, not sure if it's time of incident or not, but this startles me that marijuana is such a factor, and opiates in particular are much less when we have policies pushed by some of my colleagues that want to expand the use of marijuana in place of opiates. And we know that it's a critical factor in these infant deaths. Why we would want to replace one for the other when we know that marijuana is impacting these fatalities at such a rate, that is a very big concern to me. I mean, we've had discussions over the last several years about legalizing medical marijuana, expanding the use of marijuana, and we've seen states like Colorado experience increases in emergency room visits and child fatalities, and I don't want to see Indiana go down that same path. I'm just wondering if the department is as concerned if we increase the use of marijuana that it will impact these statistics to an even greater rate.
Honestly, I'm not sure if I can speak to that. The information that we collected was from 1 year of sleep-related deaths, and so I'm honestly not sure that I can speak.
So you haven't tracked any of this since the data from 2014?
We have not. That may be what the state team decides to do.
I would think that would be very important since 2014, that was 4 years ago, and since that time we've had a significant policy change in House Bill 1006, which was our criminal code reform, which was reducing penalties across the board for issues related to drugs. So it might stand to show that if you have reduced penalties related to drugs, that you may have more substance use going on in the home. And I would be interested to know what these numbers look like today, certainly since we've had 4 years of time span to study it. I mean, quite frankly, I'm surprised that we're going over data that is 4 years old. It needs to be updated urgently.
Well, and again, I hope that we can use this report to help the local teams understand really how important it is that I know that they're meeting and they're reviewing these deaths. They're just not putting the data in like they should be. So my hope is that, and the state team's hope is that we can use this information to help the local teams understand how important it is to conduct these reviews in a timely manner and enter the data in a timely manner, so we have more real-time So we had to basically pull all of these records from DCS and autopsy reports from coroners, and it took a lot of time to gather all of this information when the local team should have it, and they should be entering it. So hopefully we'll hear in August if we receive some money to help fund this. It will also provide some funding to coroners to help pay for autopsies, things like x-rays that we're not getting, probably due to funding. So hopefully we'll have a little more support to carry forward with that.
Wasn't 2014 the first year that we switched child fatality over to a different agency? No?
2013.
2013 was the first year. So this could be a baseline. Is the plan to continue, I mean, this is important information with regard to looking at infant mortality, so to continue to give this kind of in-depth study for a current year.
Just to follow up with the senator, and I appreciate her concerns, I have that as well. We had a concurrent resolution to look at medical marijuana this summer, and I know it's almost impossible to update information by then, but maybe even preliminary. I don't know that, but I would think that you need to be there with information, because I think anybody would be there with, if you can get updated on it, you have the time to do so, but this is startling. This is very scary. And I know it's just medical marijuana, but I can tell you what I get concerned with is that's the first step to just, we start to talk about marijuana, legalizing that, and that's where I'm very, very concerned about at this point. Just
A couple of questions. You say data, and you talk about local teams. Are you talking about the local child fatality review teams?
Yes.
And so those teams are supposed to submit reports to the state team. Is that done longhand or is there a text system, a computer system where you input that?
It is a web-based system.
So it's a web-based system. Is that the local DCS office is supposed to input that, or is there someone on that team that's designated to input that data? I'm a little concerned that you say you're not getting the data. If these teams are meeting, what can we do about that? I mean,
Yeah, we're hoping to provide some training to the local teams and work with the National Center for Fatality Review Prevention to do that. There's also a graph in the report that kind of outlines where Indiana falls compared to the nation as far as our child fatality teams entering data. And actually, we're doing better than the national average in some ways. We're entering data, but what I found is that there's a lot of unknowns. So we have teams that are just kind of checking unknown instead of really going in and asking those questions. So we hope to provide some training and use this report really as the focus of here's what your information can do and here's how impactful.
how much?
One more, quickly, because we're
How much of
over
this is
time.
driven by the problems in our coroner system where, I've had this experience as a prosecutor where the coroner's not a medical person, they had a baby death, they rule it natural causes, don't do an autopsy, and then I get a call later that it's something else. We got to go through the process of seeing what happened to this baby. I mean, would a medical examiner system or some, seems to me that's the trigger, right? You got a dead person, in this case a child, and oftentimes the coroner's the first one there if it's at home. Maybe that, if you don't have the information, it seems to me that may be why. I don't know. You know your thoughts on that?
I'm not sure I can speak to whether medical examiner or coroner system would be more appropriate, but I think I can speak to the fact that we need to do a better job of educating the coroners on how to accurately identify and classify these deaths. And I think it's just really difficult without some really direct guidance. And so again, that's kind of, we brought some speakers to the coroners conference to help that. And again, hopefully this report will help provide some training and education to coroners as well.
We had two designees that had to raise their hand. If you could, yes.
I just want to mention about the fatality review team. It used to be with the Department of Child Services, and now it's with the local prosecutors' offices. Is that right?
The prosecutor set up the team, and then the team chooses their own chair, and they are supposed to have someone identified to their data.
I was just saying that if there was going to be training, needed help, you might be able to call the data for help because since he's a.
Well, that's what I was wondering, and I know we're involved in one of those teams, but I don't know if anybody's been designated as responsible for putting the data
Each team usually has someone who's.
So it's sort of a local issue.
But you're saying that it's not going in, so each team may have some, so really, so we're gonna have Dave Powell look into this too, right?
Yeah, that's fine.
And then Martha, you had something quickly you wanted
Yes,
to.
absolutely. The perinatal substance use study that I presented on previously, we do track all of the factors you've been talking about, so it includes alcohol, barbiturates, methamphetamines. So that is real-time data reflective as recent as late March, so we can report out on current rates.
Is it on your website?
It's not on the 2017 report is, the most recent data has not yet been released, but I can certainly provide it.
If you can give it to Julie, and then Julie can disseminate it to the committee, that'd be helpful.
So
Thank
that
you.
is, it's not reflective of the child fatality review work, but it's testing positive, so it gives us a reflection of things like marijuana use.
Thank you.
Do you want to sum up your recommendations in 30 seconds?
I think we've really talked about this, but the summary of our recommendations are that the death scene investigations should be using the SUI protocol, that CDC protocol, so we have standardized death scene investigations, collecting the information necessary for pathologists to determine cause of imminent death. That the local team should employ the SUI case registry algorithm when they're doing these reviews, so we're all looking at this the same way. And the death certifiers and coroners should adopt the CDC definitions for types of SUID, those SIDS, external certification strangulation that are undetermined or unknown. And that local team should use the child death reporting system and data to implement evidence-based programs and activities in their area.
Thank you. You did an excellent job answering a lot of tough questions. So, thank you. All right, John Travis and Judge Pratt. An update on the possible external review of Indiana's juvenile justice system and technical assistance.
First of all, I'll apologize on behalf of Judge Pratt. He was on a trip back to Pennsylvania yesterday for SBK. And apparently he ran into a deer. So he's okay. He just was unable to be here this morning. Maybe lunch meeting. I'm sorry. I apologize. My presentation is going to be real short today. We have been working with the executive committee of the commission to keep them updated. We have, again, our task force was looking at several different issues, mainly regarding the best options for status offenders, funding for juvenile services. We looked at the minimum age of the baby in delinquency, and over the past 6 months, we've been engaging in conversations with the Center for State Court Governance to help us look at this across the state of Indiana and across the country. Because of some possible conflicts with the current report being done for the Department of Child Services, particularly with some of these aspects, the timeline for CSG to do their study could cross or need to be done now. We didn't want that. We want to be, we want to make sure that the CWG report got its proper respect. So we went in contact with CSG, and they suggested a couple options for us. One would be slow down the process and do this full assessment next year. One is we partner with CSG, and the third is they suggested us to contact Future Trust and does similar work, and they do it in a shorter time. We met with our task force, and we kind of looked at two options. One would be continue our discussion with CSG and look at possible next year, but we've also engaged in discussions with Future Trusts. And just that fact that we have those conversations, I believe next Monday we're going to have a formal conversation with you to see what they can do to help us with our targets if we want to.
Just a quick side, just a little background.
Yes.
We had asked for the commission, you know this, Travis, while the state is looking at DCS and looking at where are we, how do we go forward, what are the issues, we thought that we would also look at particularly status offenders in the juvenile justice field, and we tried to see if they would do a scope of work around that and not duplicate the evaluation being done that we don't have yet on Department of Child Services. They couldn't give you a limited scope of work. So we decided that we're not going to duplicate it. We'll see if we can get somebody else to look at it. Because nationally, the idea of 11-year-old truant who's maybe running away because there's molester, unmet mental health needs. How are we delivering services in Indiana to those children, both in the judicial branch and the other branches of government? So that's just, I don't know if they had all that background. So you're saying that your committee is looking at that because we also want an evaluation in this area, and you're trying to figure out the best mode that we can get that in, at no cost.
Absolutely. If we start thinking about status offenders, they occupy kind of a unique role currently in the delinquency aspect of the juvenile code. However, the disposition alternatives for those kids replicate more of the chin side, because those kids cannot be sent to the Department of Corrections, they cannot be placed in secure detention. We had a couple of legislative actions over the last several years that took some loopholes out of the statute that no longer allow the status offenders. So dispositionally, they replicate more of the chins than they do a delinquent offense. So they kind of fall into this strange category. There are states across the country that have these status offenders on their chins. We have other delinquents, and we want to actually try to determine the best place in the state of Indiana for those. But from that conversation, we also started looking at the age. And Indiana does not have a lower floor limit for age. So juvenile probation department see kids as young as 4, 5, 6, 7 years old coming in for shoplifting or other type of offenses into the juvenile delinquency system. Hopefully most of those are diverted, or there's other options that are taken care of. Indiana just doesn't have that under age limit, and that's one of the things that came out of our inspection.
So your task force is going to continue to look at that. Any other questions? Thank you, task force. You're doing some great work. All right, strategic priority on mental health and substance abuse. Rilla Blackman from Department of Mental Health.
Good morning.
Good morning.
Since our last update.
Could you speak up just a little bit?
Since our last update.
Maybe it is on. Is the microphone on?
The green light is.
Okay, maybe move that over towards you a little bit more.
Okay. Since our last update, we're continuing to look at our priorities and really streamlining so they're more specific and targeted. And so we will be looking at moving some of our deadlines a little further and really honing in on specific strategies. We also realize, as we're talking about school-based mental health and identifying gaps, we'll be working with the Education Task Force, who's also looking at that from another perspective. And also we'll be including efforts being made through our school-based grants. We received last year to fund addiction prevention programs and social-emotional health as well. So we'll be looking at all of those services and seeing what the strengths are, what the gaps are, and make recommendations what needs to happen.
Any questions? All right, thank you. All right, educational outcomes.
I just wanted to share something good. We have mental health awareness coming up in May. And I just wanted to share this initiative and give you an idea of the wonderful artwork expressions of our youth throughout the state. So our National Child Mental Health Awareness Day, through SAMHSA, they have it every year to talk about the importance of children's mental health and to show that positive mental health is essential to a child's healthy development from birth. So we'll be celebrating that this year on May 10th. The theme this year is Partnering for Health and Hope Following Trauma. This year's national service focuses on the importance of integrated health approach to supporting children, youth, and young adults with serious emotional disturbances who have experienced trauma, which I think falls nicely in line to our initiatives. I want to talk about the overview of Indiana efforts. The Division of Mental Health and Addiction partner and support the children's mental health awareness with the development of a committee whose members are made up of other state agencies and local stakeholders. Last year was the first year we initiated the art competition. What we did, we had schools look at a video about mental health, how to decrease stigma among students, and we sent out notices out to the school districts. And last year we only received 17 entries, but the art was fabulous. So for this year, we really have worked hard with our collaboration with the Department of Education. And the one thing we really realized is with our school-based grants, a lot of schools put in applications to receive money for support for mental health and addiction programs. So we reached out to them, we sat and talked, we shared information. And for that, we utilized this year's the announcement of the student art competition was disseminated to DOE school counselors and social work listservs and school safety officers. So the artwork that was submitted comprised of varied levels of mediums, sketches, canvas, oils, poems. We had video. It was really, truly inspirational. So from the high school students, this just gives you an idea how many were from the freshman class, sophomore, junior, and senior. We had 19 participating schools, and as you can see, from northern to the southern part of the state, we're hoping going forward we can get all schools and we'll have a full state representation. The students titled their own art pieces. I will not read their narrative, but what was impressive to me was the fact that this started out as a mental health project, and they really, in doing their art, expressed their own challenges and struggles with their own mental health. This piece, for instance, really captured statistics of the future. This student really focused on statistics from 2014 of the rates of deaths by suicide by age, which you can see as the shoes. The Converse is hanging, and each knot in the shoelace for each shoe represents the rate of suicide, which to me, I thought, wow, that's really impactful. Post-purgatory, just saying that it doesn't have to end. There is a light after the tunnel, and there's beauty, and another just wonderful piece. Thoughts, we look at how many times students feel stressed, depressed, and they put on a smile, not just students, I would say a lot of times, many of us at different points in times in our life. Thought that was illustrated very nicely. I really like this one. Spreading color in life's garden, to realize there are people around you to support you and to help you make it through, maintaining a healthy state of mind. Out of the 140 submissions, this was the only one that focused on addiction. And I'm not sure if it's because the title was mental health or what, but I would have loved to see more of that. This is see something, do something. Sometimes it only takes one word for someone to ask how you're doing to make a difference. Lost in thoughts. Really, this doesn't do it justice. This is a very beautiful piece. Just how we get distracted and consumed and having difficulty focus on what is important. Well, this one I thought illustrated the feeling very well, being overwhelmed. I think most of us can relate to wanting to throw our hair out at any given point in time. This one, as you can see, she put a lot of thought into it, just wanting to express that she's dealing with anxiety and obsessive compulsive disorder, and how laughter is its own medicine in helping an individual feel better. Believe in yourself and you'll thrive. It's really like this little cat looking in the mirror of a lion. Overcoming darkness, finding your self-worth. How to never stop being sad. This piece, what I forgot to mention, that the judges for this art competition were students from the Heron School of Art. And so this one was one of the top pieces that was selected. Words kill. This theme is around bullying and how words can be very hurtful and make you feel worthless inside. Sinking slowly. When I was talking about the different mediums, this is one that was in water, trying to balance emerging and having that balance of hope. Deafening silence, all the negative messages that are used here. And finally, the really positive one is You're Enough, and how we can, if someone's struggling with mental health, depression, to say those affirmations to yourself. I would like to have special recognition for our Children's Mental Health Committee members, Bethany Eckler from the Division of Mental Health and Addiction, Amanda Reuter from Adult and Child Community Mental Health Center, Connie Young from Ethicists Say First Steps, Julie Bingham, Indiana Center for Children and Families, Denise Center for Reach for Youth, Dr. Angela Tomlin from Raleigh Child Development Center, and Rebecca Goral, Mental Health of America, Indiana. So I ended it with Dr. Seuss saying, be who you are and say what you feel, because those who mind don't matter, and those who matter don't mind.
How fun. How fun. Those pictures are amazing. Thank you.
Well, the artwork will go on display, and we have our mental health symposium. We'll have pieces of students who would like to volunteer to have those. We didn't expect the quantity and the high quality. We also offer to get them framed, or because some of the pieces are large and on different mediums. And so we were thinking maybe for next year we can do something more like prints and cards, because the work is really nice.
I wonder if we could put some of the pictures in the annual report.
Yeah, that would be great.
Last year's paintings in the forum for the conference, there were just, hordes of people standing around them, silently weeping. I mean, they just were.
They're powerful.
Yes.
I would just,
great.
being the lawyer here, I would just make sure you got their approval. I'm currently being sued by someone because we.
No, that's why I said for the future. I'm very aware of that.
Make sure we get the kids' approval.
Yeah.
Their photo.
And we want to be able to, with so many pieces, to be able to recognize those students and the schools for making this a successful child mental health awareness day as well.
It's wonderful. Thank you.
Thank
you. Tell your whole committee thank you. That's a great idea. Educational outcomes. Monia Grant or Kathy Bennett?
Good morning.
Good morning.
So, we'll be quick. I was looking to see if my co-chair was joining me today. Hi. We just have a quick little couple updates here. We are working towards completion on our passport model, which is really exciting. We have uploaded and changed some of our deadlines because we were a little over ambitious with our deadlines prior to for our deliverables.
Can you explain for some of our newer members what the educational passport, because we've talked about it before, but everybody may not know what that is.
So one of our tasks is to develop an educational passport to provide a comprehensive understanding of the educational history of our vulnerable children population and youth, and when they move from place to place, so that their school academic growth can be tracked, so nothing gets lost along the way.
Like the young man that was here, who had been 18 different places, when a child gets placed in foster care and the educational records don't keep up.
Right, right. And not just foster care, but when they transition, or if they transition between the different agencies, they can be lost through those different agencies. So they're currently tracking 3 different models and researching those to see if they would be beneficial to be recommended to the executive committee to be implemented into the school corporations. One thing that we wanted to make sure that they were looking at is all of the youth defined under the vulnerable youth definition per the commission. So they are making sure that they are working on that now, because it seemed as though they were working specifically for the juvenile justice population. So we have made sure that they have gone back to review all of the populations within that definition. And so one thing that we're working on, we have 3 subcommittees working right now towards 3 of our top priority objectives. So the second objective that we are working on was our wraparound services co-located in the school corporations. And our co-chair was Dr. Terry Miller, and she's here today, and she's doing an amazing job. In looking at that, they've asked the commission, they've asked us to bring it to the commission to ask if we can reword the task that we've been assigned so that it does not contain the word wraparound, because it can be very confusing between the mental health services, system of care, and education services on what wraparound really is. So we'd like to propose that we change our objective wording to advocate for additional and improved services integrated in schools to address mental health and wellness. It says the same thing.
Just deletes the word wraparound.
Takes wraparound out and puts the meaning of what we were given from the commission of what wraparound is to be. So we'd like to ask if you all would be able
Any questions on that? Any questions on deleting the action item for the education committee to delete the word wraparound? Is there a motion?
So moved.
Second? Second. Any other discussion? All those in favor say aye.
Aye.
Any opposed? Well, that's the easiest thing.
Thank you. Thank you very much. And we do have a couple other pieces to that. We had identified some deliverables within that so that we had 4 separate reports that were going to be coming from the work of that subcommittee. And upon Dr. Miller's work with her subcommittee, they have identified that we can actually push 3 of them into one report because they build on each other, and it makes more sense to have them within one report. So she has identified their expected deliverable to be changed to a report of infrastructure, resources, and evidence-based recommendations for mental health support and collaborations in schools. So it takes 3 of them and condenses into one. And they are working with the Indiana School Mental Health Initiative and Remedy Live to gather statewide information in the area of social and emotional learning needs, as well as the Collaborative of Academic and Social Learning, which is CASEL. Thank you. School Health Assessment and Performance, which is the SHAPE system, and the CDC grant work has also been discussed and shared, and they are planning to work with the Trauma Informed Subcommittee that Dr. Zachary Adams is working on to share that information so duplication is not occurring. And we also discovered today that through Cirilla at the DMHA, that we need to also share with their subcommittee that's working on that so that we have a good collaboration between all the task forces that are dedicated to working on this mission.
And then could I add a footnote about the CDC grant, that the Department of Education applied for the CDC grant that we're talking about that collaborates with their work. In the past, we applied for the CDC grant and defined chronic illness as diabetes and asthma, which is frequently why students are absent for those reasons. So this CDC grant that we applied for, we defined chronic illness as mental health, which would be anxiety and depression, so that we can link schools with better mental health collaborative services. And sadly, on the hills of Parkland, that is a huge gap that has been identified. So hopefully we will get that grant and be in good shape to cross or to merge all those. I don't even know what proper analogy, but bring everything together, converge things so that we're all working together on that need at schools.
Wonderful.
And then the other piece is the remaining deliverable that is not being absorbed into one is the report of training and education recommendations for the school-based mental health professionals. And they have sent out a survey, but I know there's questions about what that survey contains to the CMHCs. They've currently received only 3 responses, so they're waiting for more of those. And Cirilla today has advised that if you could send that to her, she can send it out through Catherine and maybe get a more positive response base. So that's where our next steps are with this subcommittee. So I think we're actually progressing quite well with this particular work.
You are. Yeah, thank you. Thank you very much.
And then we have one more thing. Well, we have 2 more things. I know I think I'm taking more than my 2 minutes, I'm sorry. We are working on our discipline and climate and the school corporation subcommittee, working on making sure that this proportionality is being addressed and to stop the tide of bullying. And with HB 1421 passing, 1421?
1421, yes. What we've done is we've added a co-chair to that committee, Kristen Martin from the Marion County Prosecutor's Office, because of her work with reduction of education neglect cases and working on prevention of truancy, et cetera, and looking at the whole discipline and disproportionality. She's also a data geek, so that would be really helpful to that committee. And we're gonna pull the 2 co-chairs together with Melina and I to look at how that can become an advisory group to the Department of Education, so that we can follow through on what's required by 1421, which the first step is a survey that needs to go out, and the report is due, I want to say, September 1st. So that was a very quick deadline for any government agency to meet, but we're already working on that survey, and then working on some of the implementation of evidence-based plans and professional development, which is part of that piece of legislation. So I think that would be a really good group to utilize for helping the Department of Education move forward on that legislation. Does that make sense?
Yes.
Okay.
Any other questions?
So we're moving forward.
You are.
Slowly but surely we're getting there.
And then the fourth is the study and report on the graduation rate of vulnerable youth. We had previously thought we had met a very significant wall, but we have heard otherwise through 2 major ways. NPH has a data sharing agreement with DCS, and with FSSA is coming along a little bit more to where we're getting closer to sharing with the FSSA. But then also with the passing of HB 1314, we will have a huge chunk of data as far as graduation rates, as well as the disaggregated population for foster youth and homeless youth, which is a huge section of our vulnerable youth in Indiana. So we're very excited about that. So we will actually be able to have those graduation rates and know where those gaps lie and how we can better support our youth. So that's some positive information about that. And we because of that, we have changed our deadline to January 2019, because we should be able to have data by then. So it's really exciting.
That's great. We've been talking about that for 5 years.
I know.
That's wonderful.
Finally, we've done it.
Yeah. So we're
Yes. So yes, it's happening. So we will be able to have that data in hand and be able to report out. And we talked about how to get the data analyzed by the experts and getting a committee together through the experts at hand that can actually analyze that data and provide us with some good information.
Wonderful. Thank you very much. All right, data sharing and mapping committee update. Tamara Weaver and Tyler Brown.
So unfortunately, Tamara couldn't be here today, and Tyler got called back to his office for a meeting. So I'll just give you the very, very short update that committee is looking to add some additional members. We talked about Garrett from DCS. There are a couple other holes that they've identified that they're going to be reaching out probably to some of your staff, particularly in the area of business intelligence, or so those folks who either are in the data or maybe one step above in terms of policy, but closely understanding data. So they're looking to build the committee a little bit more. And then they're working on 2 specific requests, the one that Milena mentioned around educational outcomes, and then another one that was submitted by Cirilla on behalf of an interagency group of staff of many of your agencies that really want to look at overlap of children served by the different agencies. And so the data sharing committee is going to kind of step through how to really implement and get those data sets pulled with the help of MPH. But there's a lot of just kind of thinking and organizing and getting down to the detail that the committee can help with on those 2 really significant data share requests. So that's what that committee's working on.
Thank you. We're going to hear from you again. Catherine Dolan, Communications.
Good morning.
Morning.
In the back. I know it's a little tough to hear back there. I'm pleased to report that our communication efforts are moving forward. We're recognizing, though, that we do have a gap in communication representation from a couple of areas, specifically from the General Assembly. We've reached out to leaders of each caucus to ask that they consider having their representative attend our communication meetings. We had been meeting on a monthly basis, which is a lot, but we needed to get things going. So now we're moving to an every other month basis. And so we're looking to really expand our membership to ensure that we're meeting all of the communication needs. We have a wonderful group of professionals. Our FSSA representative, Joe Gavin, who was here a little bit earlier. We have Will Wingfield from Indiana Criminal Justice Institute. So we really have nice representation. We talked extensively about the annual report, which is due on July 1st. Your next meeting, though, is June 20th, and the executive committee really wanted the information from the June 20th meeting to be included in the report. As Julie met with Representative Frizzell, he indicated that we could be a little late on that deadline, and so what we're formally asking from this group respectfully is to give the executive committee the authority to submit the report and to finalize the report. And we will be working on a deadline that includes gathering information from all of the chairs to submit to Julie to bring together your hard work of the past year so that that annual report can be formally submitted a little bit past the July 1st deadline. Our goal is to provide it by August 15th.
So we would file a report on July 1 saying that we want to include the entire year as opposed to a partial year, and it will be August 15th. Our legislative representatives thought that would suffice. So is there a motion to allow it'll all go to all of you for approval. Is there a motion that we file a report, that the report will be still emitted this summer, no later than August 15th? Is there a motion? All right, second?
Second.
Any other discussion? All those in favor say aye. Aye. Opposed? All right.
Thank you. And our next communication meeting is May 10th. So if you can urge your communication folks to attend, we'd very much appreciate it. Thank you.
Thank you, Ken.
Yes, when you said you identified a gap, and are you looking for actual, the gap is maybe for communicating with legislators, so you're looking for actual legislators so that they can communicate with themselves, or you're looking for staff?
Senator, I think that what we really like is what I would call my counterpart. So, for example, Connie has been attending from the prosecutors, who's essentially my counterpart, the spokesperson PIO for the prosecutors. We have Jim Gavin from FSSA. So if we can get the 4 legislative caucuses to have their communication professionals, their PIOs or communication strategists, attend our communication subcommittees, we think that that may help continue to keep the flow of information moving.
And how would you like us to do? When you send out?
We have contacted them, and I'm happy to forward to you the email letter that we've made the request saying, can you join us? It's a lovely, friendly group of people.
Up with the Senate Democrat.
Wonderful. We would be thrilled, and I'll hand you my card before you leave today and forward you that information.
All right, thank you, Catherine. All right, Julie Whitman. I will say the annual report is going to look different this year. I mean, this is the first year with regard to the executive director. We have a lot with the strategic plan. We have a lot of action items that and deliverables that will be highlighted in the report.
Okay, thank you, everyone. So one kind of substantive thing that I wanted to introduce today, and I honestly can't remember if I've mentioned it before in this group. I've brought it to the executive committee a couple of times. A project that I would be really interested in spearheading over this calendar year is called a children's fiscal map. And so I wanted to just kind of introduce the concept. I've had some conversations with Jason regarding this. You could also call it a children's budget. The idea is that it's a document that shows all the money that the state is investing in children and youth, whether those are state dollars or federal dollars, whether they're passed through or specially appropriated. To kind of look at, it's really looking at budget data that's already there, but in a different way. So when you look at the state budget, which I'm sure you all do, have a copy on your desk, refer to it regularly, it's organized by agencies, right? And then sometimes by, sort of specific lines within the agencies. This would be that same data, but organized by population and by type of service. So that's just something that we've been having some conversations on. I realized that I have a link here that I don't know how to work with the remote. Yeah, that's not going to work. I need a mouse. I was going to show you an example, but at any rate, there is a report from Virginia that I like very much that I want to use as kind of a model. I'm sure ours will look different, but it's on the, oh yeah, maybe you can just hit the, can you click on the link for me? See if that works. You might have to go out of the PowerPoint. At any rate, the full report from Virginia is on the Children's Commission website. I didn't print it out for your packets because it's like 75 pages, but there is a link to it on the website on today's meeting page. So you can just kind of see different ways that that information can be presented. The purposes of doing it, why would we do this? It can help with planning, it can help with identifying sort of what are the different funding streams, and do those things match with what our policy priorities are? Do those things match with what our kids need? So it's just kind of starting with a baseline of what are we spending on kids, in what areas. We know, for example, we already know, I can tell you without ever having looked at the data, that Medicaid is going to be a huge portion of that spending for kids, right? That's one of the big major state expenses, as is education. But when you get beyond those two big buckets, and even within those, there could be some interesting programmatic elements, right? And then what else? What else are we looking at for vulnerable youth? And again, how does it match what we say our policy priorities are? And of course, everyone around this table might have different policy priorities, but that's the beauty of this tool, is anybody can use it, and you can say, okay, here's where we're at, and this is where we think we should be. Another way that some of the other states who've done this have used it is to identify funding streams that are vulnerable or expiring, and in particular, when you're looking at some federal funding, sometimes, what I think they found in Virginia is that, or maybe it was Tennessee I looked at, some of their program areas were very heavily reliant on federal funds that were in danger of not being renewed. We've seen that already with CHIP, So sometimes there's things that looking at the data, the financial data in this way can kind of go, oh, look at this chunk of funding here is vulnerable. What does that mean for us? What do we need to do? So it just kind of provides some data for the conversation. I guess I'll just stop there. Any questions about the concept? I may bring you something at the next meeting that's a little bit more formal for approval, like a project charter, but I wanted to have enough time to go through that with the executive committee, and Jason's been really helpful in kind of helping me understand what data is available and how can we get the different agency CFOs involved in kind of getting this data in a way that doesn't create a whole bunch of new work for them. That would be my last objective. I don't want to do that, but in a way that kind of works with existing systems, but we can look at the data in a different way.
That sounds excellent.
Okay, good. Then my other updates are just really, really brief. I included in your packet my final bill list. It's top 50, 50 things that passed that I think will have an impact on kids. And just to maybe highlight a few that really, that have the commission has talked about before or will have a specific role with. Two of them actually were already discussed by the executive, the education committee, the 13-14 data on foster youth, which is pretty exciting, and then 1421 around school discipline. Both of those dovetail very nicely with some objectives that we've already had for a few years. So we're looking forward to helping with the implementation of that, or at least getting the information that comes out of that. If Dr. Box were able to be here under health, she'd want me to highlight SEA 360, the perinatal levels of care. That's a big game changer for the infant mortality conversation, making sure that hospitals are accurately labeled as level 1, 2, 3, that they're meeting standards according to the label that they carry, and that moms are delivering at risk appropriate facilities whenever that knowledge is available. Under mental health and substance abuse, SEA 224 came directly from the commission, which is exciting. That's our kind of one task force recommendation that came all the way through the process this year. It came out of the mental health and substance abuse task force, was carried by Senator Head, and did pass both chambers. So that you all can congratulate yourselves for. That was an achievement of this commission, and really great work by Senator Head in particular, who really moved that through the legislature. Under child welfare, actually the one that I kind of picked to highlight is 1248, which doesn't have anything to do with DCS, but I put it in child welfare because it has to do with the welfare of children, and that's the Silver Alert for kids with disabilities. This was another kind of just a good piece of legislation that fills a gap. So we have Amber Alerts for children who are abducted. We have Silver Alerts for elders with cognitive challenges that maybe wander away and can't get home. We didn't have anything for kids with cognitive challenges who might wander away and not be able to come home. And this piece of legislation corrects that gap. So I just thought that was pretty cool. HEA 1270, human trafficking under the criminal justice section. This is the one that actually gives us a job. It mentions the commission specifically and asks us to study a very specific topic related to child victims of trafficking. You all probably know a couple years ago, juvenile prostitution was removed from the criminal code. We said juveniles who are being prostituted are actually trafficking victims, and so those are actually children in need of services. It was created as a DCS category. So there's a little bit of follow-up here. What they want us to look at is if law enforcement encounters one of these, let's say a teenager, most likely, who they suspect is a victim of trafficking, on what authority can they hold that kid until they can get to services with DCS? And so it's a really kind of narrow, specific question that they asked us to look at. My recommendation would be that you assign that study to the Juvenile Justice and Cross System Task Force, which has a subcommittee that's actually specifically looking at trafficking of children.
Any objection to that? I don't think we need a motion. I think it should go there. All right.
Okay. So that's it on the legislative. Again, you have the full my summary there, and there are other agencies out there who do summaries of kid-related legislation, but that's kind of what I was following. Third thing I wanted to mention is that I've been out on the road, doing a little bit of public speaking to try to raise the profile of the commission, and also get some community input for the work that we're doing and the work that your task forces are doing. So I've been presenting the strategic plan at conferences, and I actually came up with a little worksheet to try to get people's reactions to the strategic plan, particularly practitioners in the field who are working with kids. I spoke at the Indiana After School Network. I spoke at a juvenile summit in Elkhart that was very multidisciplinary. I will be speaking coming up at the Systems of Care Conference and the First Steps Conference. And so the goal is, again, to make sure everyone who's working, well, everyone, as many as possible, people who are working with kids in the state of Indiana know about this commission and what it's doing, and that they have an opportunity to provide some input. So I asked them for their reaction to the strategic goal areas that we're working on, what objectives really stand out to them, what good work is already being done in those areas, so we can kind of capture that. And then I also asked them what's not on the strategic plan that should be, so we can start lining up some issues that we'll tackle next once we get through the current plan. So if you have or know of other opportunities where I can get out and speak to groups, whether it's at a statewide conference or a local, local gathering, I'm really happy to go and do that. I'm really interested actually in getting outside of central Indiana to some of the other communities around the state. So just let me know if you have ideas on that. I won't go into strategic plan implementation because I think the task forces did a great job on their updates. But I'll just reiterate that tracking document is in your packet every time. We've worked on how to get kind of better timing to make sure I have their updates in time for when I print the update for you, because I think I have new information even since I printed the one that's in your packet. But we'll just kind of keep that moving. One of the goals for this year is to really make sure that we're moving on that strategic plan, and we are. And the task forces are doing some really great work on those objectives. You heard several of them say we're changing our deadlines. They're finding that some of these things are taking longer, which is a testament to their optimism when they set their original deadlines, but they are working and they're really moving those things forward. And just as a reminder, the strategic plan is to go through 2019. So we have this year and next year to kind of check off those objectives and we're making progress.
A couple things. One, there's legislation to change the sunset of the Children's Commission.
Oh, yes. That's right. That was SEA 238, I believe. It was wrapped into the, it was really an update of the courts when the Office of Judicial Administration was created. It kind of did a lot of name changes, but one of the things that was in that bill was also moving out the sunset. The commission was set to sunset actually January 1st of 2019, and that got moved to 2029. So 2029. So we'll be around.
And then we'll have all the problems solved by 2029. Can you, I'd like to thank Jerry Salvitz from Casey. Can you introduce him? I mean, Casey continues to be a wonderful partner, and I see
Jerry
he's
Salvitz from Casey Family Programs, great support to the commission, and Casey has funded, they funded the group that created the strategic plan for us, and is kind of providing some ongoing technical support for me and for the commission.
All right, the memos go out on the executive committee meetings. They meet monthly. Any topic that you're welcome to come. All commission members are invited, and we'll continue to send you that information.
Thank you for that reminder. I did put the last 2 sets of minutes from executive committee meetings under your packet, so you have those. And those are the first Wednesday of every month. So again, everyone is welcome to come to those.
Any questions for Julie?
You made the right choice. Yeah.
You're doing good work, yeah. You're doing very good work. In the last couple of minutes, we have, as the deliverables happen from the task force or items that we're asked to look at and bring to you, any additional topics that this commission would like, as if there's not enough. But please let Julie know. And then also, Julie is available to the executive, the legislative branch with regard to any public speaking. We continue to have the information sharing app that we're getting out with regard to. That was one of our first issues we said with regard to how does a parent navigate this. So we'll continue to advertise that. Anything else from anyone on? Thank you all for coming. And our next meeting is June 20th. Thank you. Thank you.
It's good to see you. It's great to see you.